Hello and good morning everyone, and welcome to our first semester's our first seminar for semester 2, 2018. My name's Jeff Buckley, I'm the director here at Insight. It's my great pleasure to welcome you to this webinar today. Before I continue, I'd like to acknowledge the traditional owners on the land of which we're gathered today and pay respects to elders past, present and emerging, and extend that welcome to any Aboriginal and Torres Strait Islander who might be joining us in person or in webinar land today. So to kick it off, we have a great interstate guest to kick off the semester. Petra Staiger is from Deakin University and is part of our kind of APSAD partnership for this semester seminar series. Petra is a researcher and an AOD practitioner for the past 20 years and has a particular interest and focus on the intersection between evidence-based practice and practice-based evidence in the AOD world. And she's here to talk today about transdiagnostic approaches in co-occurring mental health and alcohol and drug problems. So please join me in welcoming Petra to our seminar.
Thank you. Thank you very much. I've heard fantastic things about AOD services and practitioners in Queensland, so thank you very much for inviting me along. I hope you're going to find this interesting. So one of the things that brings me, I guess, to this topic is that having worked as a clinician and as an AOD practitioner over time, I sort of feel like sometimes it's like two worlds apart in terms of having two different sort of hats. And so some of the work that I'm going to talk to you about today is my attempt to sort of bring these two worlds together. So I'd be really interested to see how successful I am and get your feedback. So, no need to be gentle, you can tell me exactly what you think. So welcome to all those people listening online as well, I hope you enjoy it. As you can see, I've got lots of collaborators, and so there's no such thing as ideas just sort of happening in isolation. And in particular, I want to acknowledge Dr. Kate Hall's work, and I'll actually be presenting as an example of a fantastic program, part of her work today. So just a quick overview. I'm going to start with a case study to really sort of illustrate my point, rather than it being sort of purely abstract. And then I'm going to talk through about what we mean by transdiagnostic approaches. And so really in a nutshell, as psychologists and in mental health services in particular, but also less so in AOD services, we manage to sort of keep the whole DSM a bit at bay. But there has been a very disorder-specific type of approach to treatment. So, if the person has depression, you do this. If the person has anxiety, you do this. If the person has a substance use disorder, you do this. Schizophrenia, etc. So it's whereas a transdiagnostic approach, which has been something that's been talked about in the last 4 or 5 years, almost in whispers in corridors, people not quite knowing what it is really cutting across all of those diagnoses, hence the transdiagnostic concept, and actually looking at underlying mechanisms. And I'll talk to you about why I think this might be a way forward, and why this approach probably more aligns with what happens in practice naturally, and it may be an opportunity for there to be a sort of greater integration. So let's see how we go with that. So I just wanted to have a reason to have that picture in my talk, because I think it's really sweet. So it's not a surprise to tell you any of these statistics, so I'm going to move along. So let's have a look at Michael. So 22-year-old, I'll just let you read the slides, but basically consuming a range of different alcohol and drugs, has had a number of severe depressive sort of symptoms and episodes, and also more recently has had PTSD symptoms as a result of an assault. His background is very similar to many sort of presentations, has a lot of psychosocial issues, not many friends, and really quick to anger, very difficult with managing frustration, So he was recently charged with aggravated assault and waiting sentencing, and so was coming along to alcohol and drug services. And so his assessment done using a sort of a diagnostic approach has had that he is dependent on a whole range of drugs, so quite significant issues, also depression, PTSD, and significant psychosocial. So this would be your sort of typical diagnostic sort of framework that you might use, as well as, of course, talking about the psychosocial elements. Yeah. So, hence. So anyway, so you've been told, okay, well, now that's his assessment. Use evidence-based treatment approaches. Okay, so you get out the literature that us lovely academics have produced volumes and volumes of, and you read some of the papers, okay, and you get some ones where they look at depression and alcohol. One of the things you notice with research papers is they tend to choose one alcohol and drug problem, so alcohol, and one mental health issues. But of course that's not always the case, is it? There's multiple, okay, so hence my illustration there. So, and more recently we have these things called meta-analyses, where people put all the numbers into a machine and come out with some sort of overall sense of what's the most effective treatment. So lo and behold, CBT and motivational interviewing are most effective. And the fact that that's actually the thing that's most researched is of course part of the thing that comes out of the black box. So, but then of course you think, well, you know, Michael doesn't just have an alcohol problem and depression, he also has cannabis and opiate issues. So then you start to read some other papers. And then you think, well, is there anything that looks at both drugs? So, and our lovely Leanne Hydes from Queensland did a study looking at MI and CBT and mindfulness, and found that it did, if you look at all three problems, and you get a significant reduction in depression, cannabis and drug use. So once again, the efficacy around CBT and motivational interviewing. But of course, what about the PTSD? He's got this, and of course, he may not be seen by mental health services. So we've got to sort of manage the PTSD. It's the thing that's resulting in him having these outbursts, most likely. So then, of course, you've got all these PTSD studies, which are various, so then you think, okay, I can't keep reading all these papers, he's arriving soon. I'll look at the treatment guidelines. Okay, so we've got the Australian ones that have just recently come out in 2016. It's not so recent anymore, is it? Time flies. And then you've got what we call the UK NICE treatment guides, which is quite a funny name. I'm not sure that it was that nice, but and then the American guidelines. Yeah, one of the things that people talk about, though, is these guidelines are very long. And if you know the ones, the Australian ones that recently came out, is about 400 pages long. So you're thinking, okay, he's arriving soon. Now, obviously, I'm being caricaturing, because clearly you don't read the literature just before. But just imagine it was your first day, okay, and you've done your training, and you're a little bit nervous, and you're thinking you want to do the right thing and read the literature. You don't have what you all have, which is years of experience, supervision, peer group consult. You don't have all that. You're a new person. You've come along, and you're wanting to do the right thing, and you're a bit anxious. Okay, and this is the literature. Okay, and I'm not saying that this is negative or bad. I'm just saying that's what the reality is. So then you think, okay, so when I pulled all this together, I thought, well, what is the evidence telling us? Because it's not all in vain. Obviously, there's been a large amount of energy gone into developing evidence-based interventions, and for good reasons, because we want to give that new practitioner who's just arrived some sense that, you know, we have an evidence base to what we do, and we know what works and what doesn't, etc., because they don't have the 10, 15 years of experience that you can draw on. And so we know that actually when we focus on, in these trials, when we actually focus on both the mental health and the substance use issues, sometimes we actually get less of a reduction in the substance use. And that's not to say we shouldn't focus on the mental health issue, but what happens is sometimes this confusion between flipping backwards and forwards between all the different issues and the different types of programs can be quite confusing to a client. We also know that severity and complexity predicts poor outcomes. We know that the more complicated the case is, the person is, etc., it's just going to be harder, and that's not anything that is new. We know that CBT and motivational interviewing is one of the most effective ways in terms of, particularly in the context of goal setting and managing the psychosocial issues around that, so it's not just done in isolation. But there seems to be mixed evidence if you're then flipping back and forwards between the depression. And I don't mean that in that one shouldn't focus on depression, it's just that maybe there needs to be a greater integration, because in these trials they occur as separate packages. Okay, so hence where I'm getting to is a greater integration down the track in my presentation. And the other thing in the mental health treatment programs, particularly the manualised ones, is that the focus for depression and PTSD is quite different. So with depression, you would use a lot more, focusing on positive scheduling activities and engaging in etc. With PTSD, that is sometimes impossible for the person. You really need to be dealing with the trauma, and you would need to use trauma-focused type interventions, which would be quite different. So it's not like you can just put all these things in the one bag. There'd have to be a different focus. So what is the evidence that I went through in lightning speed before? That's like, took me, I don't know, a couple of days of putting all that together and just wacko. But what does it not tell us? So overall, it's inconclusive, and that's one of the most frustrating things, I think, for both researchers and people reading, is that we always need another study, or because I guess you spend like maybe 2 years working on one study, and you might have 150 people, but then some didn't do as well, or maybe the intervention needed this, and so you think, okay, we need to do another one. And that's not because we want to keep our jobs. It's actually, you're supposed to laugh at this. Thanks. It's actually because research is so slow, and so often do I get asked to, do you think you could evaluate this program, or could you, come up with a new intervention? I go, 2 or 3 years, and they sort of look at me going, you're kidding, we need it next week. And it is this whole different world of service systems and academia, where you guys have these tight timelines, driven by policy and government systems, and we have these sort of research type protocols and procedures that are driven by other types of mechanisms, and so it is very difficult to bring these two together. So anyway, I digress. There's mixed evidence regarding integration, and when I say that, it's important to recognise that the way that the integration occurs in these research studies is they have these manualised programs where they deal with depression one particular way and the substance use another, and put them together in the program. And in that way, they do that in order to be able to get quality assurance, because if everyone just did everything and then you evaluated at the end, you wouldn't have any idea of what people did. So, and therein lies some of the issues, that all these trials are manualised in order to get the quality assurance, so we know what people did. But then when you translate that, people say, well, this person doesn't need that part of the manual, or this person, that doesn't fit with that. And so hence another issue about that translation. And the other thing that you noticed in some of my earliest studies was that they were all about two disorders or two issues, whereas, as you know, there's multiple complex presentations, and increasingly so, in the service system compared to decades ago. So how can we move beyond, how, as sort of clinical researchers, how can we assist the service system in a way that goes beyond these single disorder treatment studies or dual disorder treatment studies, and so that we can more closely align with clinical practice, but still maintain that research rigour and integrity in the research rigour? Otherwise, it becomes impossible to actually articulate what it is that we do. And so you've got these two worlds that I've been talking about, and trying to, that took me ages to work out how to do that. Can I tell you? So I'm always going to these, sort of conferences where, people have these amazing presentations, the things whoosh in and whoosh out, and funny pictures. I don't have anything funny. No jokes in this one, so it's me that's funny. So I said to one of my colleagues, I said, I want something interesting, and so the elephant and this is my little sort of thing. So what does the practitioner do? And I feel I can speak as a practitioner as well, so I don't feel like I'm imposing. I watched Q&A last night. Did anyone watch that, about writers and whether as a writer you can speak for another completely different either cultural group or whatever? So it was interesting, the debate around that. So obviously practice-based evidence, which many people would know about in terms of what it contains, is about training, expertise, resources, supervision, practice wisdom which accumulates, and case formulation approaches where you're bringing and integrating the holistic person and not just the disorders. And one of the things that I find myself now being able to do is I start to see patterns, and those patterns help me take a bit of shortcuts, because I think, okay, this pattern tends to mean this, and I tend to find that this works best with that. But that took ages. So when you're this new person I was talking about who's presented with Michael, you don't have all of that in the background, and I guess that's what we want to try and make sure we grow practitioners right from the start with some capacity to be able to draw on some of this literature without it becoming overwhelming like the little person with all the books. So back to I just had to bring that one back in again, just in case some of you missed it. So now, okay. So the rest of my presentation, I'm hoping I've now convinced you that we possibly might need a different approach than these disorder-specific interventions, manuals, but that's not saying we should throw them all out, because I think they've brought us a lot of benefit. And I think over the last few decades, certainly some of the work has meant that in the field it's now just common practice to have much more sort of structured approaches, being able to sort of have a sense of, okay, this works for this right now, and let's do that with this particular group of people. So what I want to talk about now is really transdiagnostic approaches, as you can imagine, have now started to become more popular because of some of the issues I've raised. But my concern is that there is lots of different types. So one of the things, and so I'm going to talk about two, but there are lots of different ways people talk about transdiagnostic approaches. One of the ways that people talk about them is where they bring together existing treatment protocols for different types of disorders, and then bring it all into the one. Okay, so really probably the most common one is the work done by David Barlow, and this is where he has called this the unified protocol. Yeah, so it's using a cognitive behavioural approach, given the amount of data on that approach, and then he uses make the core essential mechanisms and components of CBT that work for all the different types of mental health issues and substance issues, and has them in 5 sort of skilled modules. And and obviously a lot of these things would be far more aligned with the sorts of things that you're already doing, like looking at cognitive flexibility, getting people to be a little bit more flexible in there. No, I can't do that, or it has to be this way. We know that type of thinking results in a lot of issues because people are not able to sort of go with the punches, if you know what I mean, not literally. The emotional awareness and the mindfulness, the being able to countering emotional behaviours, which means like being able to sort of manage that volatility and reactivity. Also being able to understand emotions. One of the things that I find always really quite confronting, particularly when I work with adolescents, is their inability to be able to even identify, they feel things but don't actually have words for them, or and it's really, I find it really very sad, because it means that they're living in this world that's really confusing, and then a world that we take for granted, and because they haven't really had that experience of being able to label and understand even sort of things like sadness, sort of like, I don't know what that is. What do you mean? So that's an approach that has now been quite focused, and particularly in America. One of the Transdiagnostic modules is now looking at adding alcohol, some of the additional things that you might do with alcohol and drugs, into this unified protocol. So in a way, what is being delivered now, or planning to be delivered, particularly in the States, is this sort of unified protocol which can take into account substance use and mental health. I think it's a long way off, partly because in the States they've also got a very neuroscience focus, so it's very pharmacologically driven. But this is one particular way, and I'd be happy to, if you wanted to, I can send you a reference. People email me, I can send you that. I don't think they actually have the protocol available, but if you wanted to read more about it, you can. The other approach, which is the one is my preference, although I don't have a major issue with the unified protocol, is to actually address the underlying mechanisms or psychological sort of social processes that drive many of these issues. So if you sort of think of it, I guess, as sort of the thing that is the driver of the depression or the substance use or the arguments or the anxiety, etc. And so therein lies sort of something that's very dear to my heart, is around looking at what are the constructs that are common. Okay, because then we don't have to take this approach of symptom focus, but we can actually look at what underlies it. And my guess is that many of you already do that, and that's why I think this approach is going to align better if we can build a research world around it and then link the two together. So I'd be interested in your thoughts. The only thing that I've struggled with here is that there are a range of different underlying mechanisms, and it's hard to know sometimes what they are, because of course a lot of guesswork has to happen when people are not able to articulate what's going on for them. And so that's where I think the research literature actually is really helpful, in terms of we've done massive, I included, amount of studies where we look at things like what are some of the personality traits that tend to mean that you're more likely, not guaranteed, but that you're more likely to end up having issues with substances or mental health issues or interpersonal issues. And some of the work that my colleagues and I have done has meant that we've been able to identify that some of these things, like impulsivity. So if you're a highly impulsive person, you're 2 or 3 times more likely to engage in at-risk behaviours. If you're someone who's very sensation-seeking, reward-seeking, you like new things all the time, etc. Now you may then do skydiving, yeah? Or if you've got enough other sort of psychosocial disadvantages, instead of going skydiving, which is expensive, you may end up injecting heroin. Okay, so similar sort of buzz, but unless the parachute doesn't open, the heroin thing ends up. Sorry, that was. It wasn't that funny. But the point is that going down the track of long-term heroin use obviously is not a good use of your sensation-seeking traits. So anxiety sensitivity is another one. People who, there's different pathways coming into substance use. So you come through the impulsive, angry, aggressive pathway, or the anxious, depressed pathway. There's a number of them, but to me they're one of the 2 sort of ones that come to mind. And so people who are very sensitive and tend to interpret things around them as well as their own bodily sensations as there's something wrong, tend to then be more likely to use alcohol and benzodiazepines than someone who doesn't. And then anhedonia is a sort of someone who's more likely to just generally have a negative, depressed sort of outlook, and that's how they were sort of born. I mean, it's not just how they're born, because if you get someone like that but they're in a really happy, supportive environment, you can shift that personality trait, yeah? But if you're someone has that personality trait and then you're in a very stressful, disadvantaged situation, you've got 2 factors that come together, and then it's really difficult, and then you're more likely to use substances. So that's the sort of thing I'm talking about. And so more recently, people have used this type of thinking. So if you're someone who's gone through the impulsivity, sensation-seeking route to substance use, okay, or if you're someone who's gone through the anxiety, depression, you would need different approaches. Yeah, very different. The impulsive sensation-seeking person, needs to perhaps do wilderness experiences or engage, utilise that adrenaline need for and really feel meaning and engagement in something that is consuming and as drives their excitement as opposed to their drug use. Then the person who's anxious and depressed, you don't want them to be going off into the wilderness, or that would be dreadful. What you want to do is do mindfulness type exercises and really linking them in with something that is yoga, or it's a completely different. You wouldn't give the sort of sensation seeking to the person yoga. They look at you going, oh my God. And that's why mindfulness doesn't work for everyone. And that's why these research studies where they show mindfulness has some effect, it's because it works for the people coming this way, but it doesn't. Now, who wants to sit around like this when you want to be climbing up a tree? So that's where these treatments here, and Leanne Hydes has started doing some work. I do have to say that about in 2007 I mentioned that this would be a good idea in a paper that almost hasn't got taken up, but this is something that I think really makes sense to me, and it means that we don't do this one size fits all, which practitioners don't do anyway, but the research tells you that. So then there's this real sort of inconsistency. So if you were focusing on the impulsivity part and the sensation seeking, that doesn't mean the person doesn't have depression and anxiety, because after a while, if they're really impulsive and sensation seeking and engaging all these things, then the depression comes on top of that, yeah, because their lifestyle just becomes a disaster. But ultimately, if you were focused on the symptoms of depression and anxiety and did engaged in the treatment for those symptoms, as opposed to understood the personality traits that drove it in the first place, it won't work, I don't think. Because actually what's most important is to deal with some of those impulsive and underlying traits, because the mental health symptoms are suppressing it, or it means you can't see it as well. So one of the things that I've probably researched the most, and I used to always wonder why they always say academics research the thing that is somehow related to them, and I've more recently, after getting feedback from my children, is that I'm actually quite impulsive, so I think that's why I have spent 20 years trying to understand it, but it obviously lacked some insight into realising why I was sitting on that motorbike going 180 k's down the Italian freeway. Never thought, gee, that's not normal. So impulsivity lends one to do things like that the anxious, depressed person, who has that sort of more measured state, would never consider doing it. And so therefore we need to take that into account when we're doing treatment planning, and that's exactly what happens in the practitioner approach. One of the things though that I think in AOD practice is that we tend to focus on, we're quite good at doing the anxiety and depression because that's the symptoms that we sort of see, and they're so difficult and painful for the person. But I think some of the underlying issues that then lead to the relapse again, once the person's stopped using and they're feeling less anxious and depressed, if we're not dealing with some of the underlying traits like impulsivity and sensation seeking, I think personally, and I don't have categorical evidence, that that's the thing that can lead people back to relapse. And we do have some studies, so I think I mentioned that. Yeah, so if you can have a look at the studies down below in the second line, there's quite a few studies that have shown really clearly that an odds ratio risk of, if you've got this trait, you're 3 or 4 times or 5, whichever study you look at, more likely to relapse than someone who's not impulsive. Now there's obviously other things that lead to relapse as well, but one of them might be this. So dealing with impulsivity might be like a relapse prevention technique. Might not be something you do right at the beginning, but it might be something you do closer towards the end, as you're sort of saying, okay, what we need to do now is get you prepared and armoured so that you, once you're no longer using and you're out in the system floating about doing your thing, that you're not caught up in this sense that, oh well, I'll just try it once, oh well, just this once type of thinking. So 3 things that I've put up here. In contingency management, people don't really like this, no one likes it, but interesting, when I was in the UK earlier in the year, and a lot of the service systems are now using it just because it's the most effective thing that we've seen in the research sort of studies. And contingency management is basically where you pretty much provide monetary rewards or other to not using. And you can see why people, particularly governments, would like to pay everyone $200 not to use. But it's rarely effective. And it's not effective because of the, it's not effective, it's not a simplistic thing. What it means is that the person who needs these rewards, if you give them an alternative pathway and you allow them to build up enough drug-free or, sort of advantages around it, that eventually it becomes a habit. So I think we need to move away from thinking, oh, you're paying people to be drug-free, and all it takes is that, or why wouldn't they give up anyway? It's about activating a different reward pathway. It's not that you just pay them. You say, okay, at the end of the week, let's see if we can go for a whole week, and your reward is a voucher. It's a bit like what you do with people when you want to try and change behaviours. So I think that's why it's become, when people use it, it's really effective. But I think philosophically and politically, people don't like it. But I have to say, it's being used in the UK quite a bit now. Some work I've done around brain training. I got into this because I thought, so much of our work is talking, and a lot of times people have, they don't want to talk about everything all the time. And so I thought, okay, maybe we could get to the really basic brain mechanisms here without using drugs. And so Vic Manning, who's coming up next week, she's actually not talking about brain training, but her and I have done some work in this area, is looking at it's called bias modification, where you're basically just training the brain to, every time you see an alcohol picture or a drug picture or whatever, it sounds really bizarre, I know. You get a little computer thing and pictures pop up, and you just pushing the cues away, and you do it sort of 300, 400 times every day. And when we did it in a detox unit in Victoria, we got 31% difference in relapse between those people who did it. Now it was just the relapse rate, we just looked at 2 weeks, and once we got to 3 months it had washed out, but maybe if you continued it would. But I don't know, I'm not sure about the mechanisms. We're really early days in all of that, but it does sound really interesting. And I've developed a program for smoking, and if anyone's interested in it, I'm really happy to share it, because we've found it's effective, but only for young people under 30 for some reason. Could be because the brain's more, more neuroplasticity, which then is consistent with the idea that you actually are training it. So I think we need to watch this space. I came in as a skeptic because, my training was actually, would you believe, in psychodynamic psychotherapy, for goodness sakes, all this sort of couch stuff for years. And so to go from that to, saying to people, deal with your complex psychosocial disadvantage and all the trauma you've had, just press a button for a while on a computer and we'll fix your problems. I was just like, oh, Petra, what have you done? What have you done? But anyway, I just feel like if we can help people by armouring all different parts that we can engage them with, then we should try it. So anyway, cognitive training is a possibility. So mindfulness-based therapies, I don't know about this. I did a mindfulness-based group at Odyssey House, and about 1/3 really liked it and 2/3 hated it. So you guys would know much more about how responsive people are. I think the meditation element of it is even less people will do it, but I think using an ACT approach where you're actually looking at acting with awareness and just having that minute before you act, so it's quite a nice way of dealing with impulsivity, might be useful. So a broader thing than impulsivity, because I guess impulsivity is one aspect of emotional control, if you can manage your impulses, but emotion regulation has been a bit of a buzzword now for about 5 to 8 years, and so trying to get my head around that, Kate Hall and I have done a couple of reviews, and we've been trying to understand what do we mean by when people have difficulties with emotion regulation, and what parts are problematic for people. And the things that, if you look at on the third, I can't move my head, the third line down, one of the things that we find is that if you manage your negative mood via ruminations, so over and over and over again, via avoidance or suppressing, those three techniques to manage negative moods are very unhelpful for people and tend to lead to really major issues. And then combined with a limited capacity to problem solve, psychological flexibility and cognitive reappraisal, which just means reframing. You know, like yesterday when I had a concrete drilling person drill all day and it was a bit windy and and I lost my shoes and I couldn't find this. I was like, that's okay, because in Melbourne at the moment it's 7 degrees and hailing, so it's nice here. So you know what I mean, that sort of ability to do that. If that integration occurs, that's what we call healthy emotion regulation. So Kate Hall and Angela Simpson have developed a program called ERIC, which some of you would be familiar with. And I'm just going to quickly go through that for those of you who are not familiar with it, because I really feel that these types of programs that are, once again, looking at underlying processes as opposed to symptoms, so looking at our ability to manage emotions, our ability to not avoid, our ability to be psychologically flexible, but they're not just sort of, oh well, let's just do whatever we like. The literature has really driven the work that Kate's done around this. So she's identified these are the 7 or 8 emotion regulation strategies that we need to be focusing on, because that's what the literature says is helpful. And so in that respect, it's a really nice sort of integration of the literature without the sort of manualised programs that people find difficult. So ERIC. So who has heard of ERIC? Okay, so a few of you have not. So it's basically a modular transdiagnostic program, and Kate and Angela developed it for young people, but I think it's equally as helpful for older people. I think it was the focus for her being working in YSAS was obviously young people. These I'll let you read, but basically the focus around emotion regulation is that it allows people to be able to understand and accept their emotional responses. It's being able to support people to use helpful emotion regulation strategies when they're distressed, inhibit unhelpful impulsive ones, being able to control attention, which is something that these cognitive training tasks as well can help with, is, you know, attentional focus, goal directed. You know how if you sort of have, and I think a lot of people have attentional issues who have substance use. I find when you say to them, okay, let's focus on this, and then you hear about how they manage their day, it's like, oh my God, no wonder you're stressed. You know, it's just doing this and that and all over here, and it's like, so getting some structure and focus actually can really facilitate emotion regulation. And then of course the calming and soothing and having that sort of space, which is also something that doesn't happen in these sort of chaotic lifestyles. So sometimes being able to just do some of these environmental shifts that I'm sure you know, if you can just try and get some structured meal times, structured work times, leisure, bedtimes, all those sorts of things creates a sense of stability and security without even talking about emotions. Like, we don't even need to get to that, but just doing that. So Eric, has a model and domains and outcomes, etc., etc. Obviously, Kate does days of workshops, so I'm hardly going to be able to sort of illustrate it all in one 5-minute exercise. And she has a whole training and implementation model that services can engage in. And then she has the domains. And I like this. She has symbols for each of the emotion regulation components. And really the focus is about reducing vulnerability, enhancing emotional literacy, enhancing flexibility, enhancing allowing, accepting of emotions, mindfulness, tolerating discomfort, making clear, focused decisions, and having a real sense of your identity and values. And so this sort of, even though these are all the sorts of things that you would do all the time, what I like about this is because it provides a structure around what you do anyway, but it also provides, she has all these worksheets and other sort of aspects to sort of really help. And these worksheets all come from, she didn't just make them out of the top of her head, they all come from components of all these manuals that we thought, oh gosh, no one's going to use them. Her and Anne spent months and months trawling through them all and finding the most helpful ones and then using them. So I feel good that all that manualised work still had some light of day. And so, for example, don't worry about looking at all the things, but these are some for interrupting rumination. So being able to identify when you ruminate, and then being able to have some explanation of what it does, and then a really simple little strategy to stop it. You don't need to necessarily go into the whole complexity of, what happened in your childhood all the time. You can actually use very skill-based sort of strategies that allow these things to stop. Sometimes we do need to go back into our childhood, but as I learnt after I rejected psychotherapy because it went on and on and on and on and didn't always, wasn't very solution focused, that sometimes strategies are far more helpful for someone. Facing up to avoidance is really important. It's amazing how much avoiding things, and I do this, I avoid stuff and I leave it to the last minute, and then it all causes drama. People do this when they have alcohol and drug issues, except for the fact that they end up in court because they've avoided paying the fine or going to see so these are really important things. So obviously get in contact. Now I wanted to just bring up one last thing before we finish, which is that I also think it's really important that we don't forget the social sort of aspect. And as my psychology background, I just find that often we as psychology researchers, we forget that. So I wanted to make sure that I acknowledge that some of these social networks and peer groups and family system work is so essential, because social skills issues is a real problem. So let us brace in the integration of evidence and practice.
Thank you. Questions? Another question? There were some questions on the webinar about how to access your smoking cessation tool.
All right, okay. Just email me and I'll send the link. It's an online tool. At the moment, in order to access it, you have to be part of our research thing. There's no control group, so everyone gets the intervention. But if you just email me, or actually probably better than emailing me, given I might be a bit slow, email INST, so INST, INST at deakin.edu.au, so INST. So the program is called INST.
Thank you. We'll type that into the webinar dialog box. Any questions? Is there anything about using these transdiagnostic approaches with cognitive impairment?
Well, that's why the cognitive training, in a way, is useful, because it doesn't require a whole lot of complex, conversations, because it's a very basic cognitive training where you're sitting at a computer and you're being trained to, I guess, really move your attention away from the substances. But yes, I think all of these programs, we need to be considering how they get modified when people have substantial cognitive impairment. I think that's a real issue and becoming more and more something we need to focus on, absolutely.
Thanks very much. I arrived a little late, apologies. I just wondered whether trauma comes into this as an antecedent, or do you kind of categorise it differently as something that then produces anxiety and impulsivity? How does it fit in your jigsaw?
Yes. Very, very good question. I mean, trauma, I guess it depends whether you're talking about sort of an isolated event or you're talking about childhood trauma. So childhood trauma over a period of time would be seen the same as the sort of all the disadvantaging environmental triggers and interact with whatever it is. So if the childhood trauma interacts with a personality predisposition that is anxious and depressed, then the person presents in a particular way. If the childhood trauma interacts with someone who has a greater tendency for impulsivity and anger and externalizing things, then the trauma would enact by someone being aggressive themselves. So you've got, it interacts in the picture of the two different pathways, and then so obviously needs to be dealt with in the same way as you would with any sort of major psychological problem. So I think that it's all part of the mix in that jigsaw.
Any other questions or comments? Oh, I've got one more online. Okay, considering these personality traits are a big risk factor, could this program be used as a prevention strategy with adolescents with ADHD or similar diagnoses?
Yes.
So Eric, I assume.
Yes. Well, actually, interestingly enough, a group of people, researchers at NDARC, have actually developed a personality-based prevention program in schools called Preventure, and that's been currently trialled and delivered, and it's a program where you do first of all you do like a survey or an assessment tool, and it identifies whether you're someone who's more the risk-take type propensity, or more the anxiety, sensitivity, depressive tendency, or both. Some people sadly have both, and then the program modifies the intervention based on those issues. So it's really interesting. I don't know as much detail of the program, but that's exactly what that program would do. Which I think is a much better way than what's currently happening, where it's just this one-size-fits-all school programs.
Preventure.
Yep, Preventure.
Alrighty. Just before we give a round of applause, we have a recording of a seminar with with Dr. Kate Hall from 2016, where she goes through that Eric tool on the Insight YouTube channel. So if you want to go there and revisit that, you can look at those tools in more details. But please join me in thanking Petra for that wonderful introduction.
Thank you.
Very interesting indeed, and helps us at the beginning of the semester to frame all of our work in the alcohol and drug space. There's references that are in the slides which are available. If you want copies of the slides, people in the room here, please email insight@health, and we'll send you a copy of the PDF slides. And all of the references are there. And next week we'll be talking with Dr. Victoria Manning around the pathways, patient pathways study. So please join us next week at 10 a.m. Thank you everyone, have a great day.
Thank you so much. I really appreciate you coming along. Thank you.